maybe to give a background of why we decided to have this particular webinar is we have, I believe all of us have seen that Rwanda has reported several cases of Marburg virus disease. And given that Rwanda and Kenya share quite a lot, it means that we need on our end to be prepared, or at least to have some form of knowledge in regards to Marburg virus disease. And as an update, maybe I think the last updates that came from Rwanda, which was yesterday on the 2nd of October, showed that they currently have confirmed 36 cases of Marburg virus disease, with about 25 people who are currently in isolation and treatment, and they also recorded 11 mortalities. Now, given that we have, as a country, we know that there are several buses which leave Nairobi and they head to Kigali. We have airline services that also serve the Kigali-Nairobi route. So knowing that we live in a global village, it's very easy for us to have this particular condition being transmitted into our country. And we felt that it's ideal for us to have this discussion and to look at how prepared we are, and just to talk about what Marburg virus infection is. And joining me for this discussion is Dr. Duncan Nyukuri, who is a consultant physician in the infectious disease unit at Kenyatta National Hospital. And we are also joined by Dr. Linus Ndegwa, who is the head of health quality promotion at the US Center for Disease Control and Prevention, that is CDC Kenya. And we're looking forward to just having a presentation from Dr. Nyukuri, and I will give a presentation as well. And then we will have a discussion with Dr. Linus Ndegwa in regards to our preparedness and response to Marburg virus infection. So I hope this webinar will be informative to all of you who have joined in, and we will have a question and answer session after we have the presentations. So without further ado, I would like to welcome Dr. Duncan Nyukuri to take us through his presentation, and then we can continue from there. Dr. You're welcome.
Thank you, Dr. Mbuvi, for the introduction and for the update on the current situation. As Dr. Mbuvi has said, the disease is in East Africa, and we may be exposed, and it's good for us to know what to look for and how to manage potential cases in case we do encounter them. So I will start my presentation on Marburg virus disease. So before we talk about Marburg virus disease, it's important for us to remind ourselves of the viral hemorrhagic fevers, and Marburg virus is one of the viral hemorrhagic fevers. So this is a term that is used for a number of severe illnesses, which sometimes may be associated with bleeding, and it's caused by viruses that belong to the following family. So arenavirus, the best known is Lassa, and I think in Nigeria they are having a Lassa fever outbreak. Bujan we have heard of Rift Valley fever in northeastern Kenya. Flavivirus, we know of dengue fever and yellow fever, and filovirus. And this will be our talk today, and specifically Marburg. So as I said, Marburg is a filovirus, philo because of its appearance, which is thread-like, but it can also be pleomorphic, taking a number of shapes. It's a close cousin of Ebola. They share some genetic similarity, and they all belong to the filovirus. And it's a negative sense, single-stranded RNA virus. There are two variants, the Lake Victoria Marburg virus and the Raven Marburg virus. In terms of clinical presentation, they are similar, and in this presentation, we will not distinguish between the different variants. Marburg was first identified in Germany and the former Yugoslavia in 1967, and it was transmitted from African green monkeys that were imported from Uganda. And the lab workers who were working in the cities of Marburg, Berlin, and Budapest were infected. 31 of them were infected with a 7% mortality. And from there, we have had the outbreaks, two big outbreaks that I will mention. 1998-2000, so there was this group of men who were working in abandoned gold mines in DRC, and they were exposed to bats, and bats are known to carry this virus. And when they went back home, they also infected other people. 154 cases were reported with a mortality rate of up to 90%. The largest outbreak to date occurred in Angola in the year 2004. And it occurred in a pediatric ward, and it was thought to have been transmitted through contaminated transfusion equipment after they were used in a patient who subsequently was found to have Marburg, and these equipment were not properly sterilized. In total, more than 400 cases were identified with a mortality rate of more than 90%. We have had other outbreaks involving not as many patients. In Kenya, we have had 3 cases reported, 2 in 1980 and 1 in 1987. Recently in Uganda, we have had a number of outbreaks in the eastern part of Uganda. Last year, we had an outbreak in Tanzania where 8 people are infected. And if you look at the mortality rate, you can see the mortality rate ranges from 27% all the way to 100%. I think this is partly due to the virulence of the virus, but also we have to consider the healthcare setting in those various regions, and this can also affect the mortality. In terms of transmission, the natural reservoir is the fruit bat, the Rositas aegypticus. So these bats are infected with the virus, but they don't get ill and they don't die from the virus. But they do shed this virus in the various body fluids, in urine, in saliva, in feces. And if a human being is exposed to these bats or the bat fluids, then they can get infected. And an infected person can spread to another person through contact with body fluids, and pretty much any body fluids: urine, sweat, feces, saliva, vomit, or breast milk. In addition, contaminated objects can also spread the virus if they are contaminated with body fluids. There are case reports of sexual transmission through semen of men who have recovered from Marburg virus disease. And as you're going to see, the disease can persist in certain immune privileged sites and for quite a while. And once exposed, the virus enters the body through broken skin or through mucous membranes, conjunctiva, oral respiratory routes. And this leads to the infection. In terms of the infection, it infects a wide range of cells, monocytes, macrophages, and dendritic cells. These are cells of the immune system, endothelial, fibroblasts, and hepatocytes, and even cells in the adrenocortical and various epithelial systems. Preferably in the early replication stage, the monocytes, macrophages, and dendritic cells are preferred. Once these cells are infected, then the virus triggers the production and release of tissue factor from the mononuclear phagocytes. There'll also be release of pro-inflammatory cytokines, chemokines, and free oxygen radicals that can cause damage to various systems. Release of nitric oxide and prostacyclin will cause vasodilation and hypotension. And you'll find that this cascade of events actually contribute much more to the pathology and morbidity and mortality as compared to direct structural damage. Also, you'll find that there is depletion of the lymphocytes, which undergo apoptosis and necrosis. And this contributes to the lymphopenia that we see in this disease. And lastly, there are coagulation disorders. So as we said earlier, there will be release of pro-inflammatory cytokines. And this will lead to formation of thrombi in multiple organs. And eventually there'll be consumption of clotting factors, and now the patient will start also to bleed. So in terms of clinical features, incubation period is between 2 to 21 days with a median of around 7 days. In terms of presentation, it's usually an abrupt onset of symptoms. One moment someone is well, and then in the next few minutes, the patient starts experiencing fever, chills, general body weakness and malaise, muscle pains predominantly in the trunk and lower back, and a severe headache. And then this will progress by day 3 to 5. Now the patient will start having nausea, vomiting, diarrhea, anorexia, sore throat. And at this time, the patients are usually described as having a ghost-like feature, just because of these drawn features, deep-seated eyes, expressionless face, and extreme lethargy. In around a week's time, this is when we get multi-organ failure. They'll have renal failure, liver failure, hypotension, confusion, and so on. And also now, because of the DIC, they'll have massive hemorrhage. And basically, bleeding can occur from any mucosal surface, the eyes, nose, epistaxis, vomiting, coughing blood, passing blood in urine or in stool, and also even from the skin, the patient may have hemorrhage. Please note that not all patients will progress to the hemorrhage stage. Mortality can occur without the hemorrhage. And death usually occurs by around day 8 or day 9. Other clinical features that have been observed, the patients may also have a truncal maculopapular rash, described as non-itchy, chest pain, shortness of breath, which may require oxygen, hiccups, orchitis, which can be unilateral or bilateral. And if there's CNS involvement, there'll be confusion, seizures, and death. Investigation, as we said, because of involvement of the liver, they'll have transaminitis with elevated liver enzymes. The depletion of the leukocytes will lead to leukopenia. The formation of multiple thrombi will lead to thrombocytopenia and abnormal coagulation indices when the patient has DIC. Renal failure will lead to elevated creatinine and UCs. How do we diagnose Marburg? So 2 ways. As we said, it's a negative sense RNA virus. So we can use a reverse transcriptase PCR to detect the viral genes, or the various viral proteins. The antigens can be detected through ELISA. In terms of treatment, there is no specific antiviral treatment. The main treatment is supportive. The patients will lose a lot of fluid. They may be unable to eat, and they'll be dehydrated. So hydration is key. Watch out for electrolyte abnormalities because of especially the deranged renal functions, the vomiting, the diarrhea. And it may need to be corrected. Symptomatic management for pain, for fever. They may require blood transfusion because of bleeding, and also platelets and other factors as needed. The experimental treatments for Vipiravir is an antiviral developed in Japan for the treatment of influenza, and it has been tried in some clinical trials. Our good old friend remdesivir has been also tried, and also monoclonal antibodies from patients who have recovered. But again, as I said, experimental trials, Marburg is a disease that occurs sporadically, and the outbreaks usually don't last very long. So opportunities to try these treatment options has been limited. So vaccines, again, there is no approved vaccine for Marburg disease. There are a number of vaccines in development and they're being tried out. So basically, these are viruses that have been modified to express Marburg virus surface genes. So they either the recombinant vesicular stomatitis virus vaccine, the adenovirus MVA combination, which expresses both Ebola and Marburg virus antigens, or the recombinant chimpanzee adenovirus vaccine, which does the same. So again, work in progress, but no approved vaccines up to the moment. Please note that vaccines that have been developed for Ebola are not effective against Marburg because it's not the same illness. But as much as they are all filovirus, there is no cross-reactivity, basically. In terms of persistence in people who have recovered, so the virus can persist in certain immune privileged sites. In males, the testicles and the eyes. And in females, the eyes, pregnant females, women in the placenta, amniotic fluid, and fetus, and also in breast milk. There are few documented cases of relapse after patients have recovered. It's not clear whether the relapse occurred from the virus that was in the immune privileged sites or if it was an infection, but these are rare cases. Sexual transmission, this has been reported via semen up to 7 weeks. As we have said, the virus can persist in the testes in men for quite a while. For how long, we still don't know, and research is needed in this area. So what are the recommendations? So for male survivors, they should have semen testing within 3 months of disease onset, and testing should continue until 2 consecutive negative results are obtained. In the meantime, patients need to be counseled on safe sexual practice or abstinence until 2 negative semen tests are obtained. They should be provided with condoms, and the male survivors should practice safe sex and hygiene either for 12 months or until, as I've said, 2 negative tests. I think that brings us to the end of our presentations. Thank you for listening.
Thank you so much for that, Dr. Nyukuri. That was quite an informative presentation and quite a few things that we have gotten that are quite unique, especially maybe what I can take from that is how the virus is persistent even in survivors, especially when you said in the eyes, the placenta, the testes, and all those things. That was quite a wonderful presentation. Thank you so much for that. I'm sure the questions will start rolling in. But as we get to that, the other aspect of this particular presentation was now to look at, we've seen how the virus can affect people, but now we want to look at what are the IPC measures that we can take and what do we need to do. So if you'll allow me, I'll just share my screen for a second. Okay, so what Dr. Nyukuri has presented to us has been quite informative in regards to the Marburg virus disease. And so I think I'll skip some of this, including the epidemiology and we look at the epidemiology, like Dr. said, the particular bat that actually has the virus in it, and then humans come into contact with it. One of the questions I had gotten when we were still going through this was people were asking whether is it because of the people actually eating the bats, or is it what exactly could be going on? But as Dr. Nyukuri has mentioned, just being in an area where these bats are found in those caves, getting into contact with their urine, with their feces, their droppings, and things like that, can actually predispose you to become contaminated, and actually can predispose someone to actually have the virus in them. And that's how from there the human-to-human transmission begins. And we say human-to-human transmission occurs via direct contact, and where body fluids spread the virus easily. And as Dr. had also mentioned, that outbreaks are often sporadic and localized, but they do cause a significant health concern. Hence the reason why we're having this. The main symptoms, diagnosis and treatment, Dr. has delved into them quite well. And now I'll just look at the aspects of infection prevention and control. And as you continue with this, one of the things I found while doing the research on the Rwanda outbreak is that 70% of the patients who actually were confirmed cases were actually healthcare workers who were in 2 facilities in Kigali. And they're still trying to figure out who patient 0 is. And now from knowing that the people who are actually mostly affected were healthcare workers, that's what prompted us to actually have this session. And if you think about it, when you realize that it's healthcare workers who have actually been affected, it basically means that maybe we may not be practicing the ideal IPC protocols, and just basically just starting from something as simple as just the standard precautions for every single patient that we come in touch with. But then when you look at with Marburg virus disease, we're looking at things like barrier protection, where strict infection control is paramount, using the appropriate PPEs, and we will delve more into this as we continue with the presentation. We're also looking at safe burial practices to minimize transmission risk, and proper handling of bodies is actually quite critical. And the third component of this is now the environmental decontamination, and this is mostly done using chlorine-based disinfectants, especially on all what we call high-touch surfaces. And most of these lessons, we're actually carrying them forward from the time when we had COVID-19, and we're looking at how do we prepare ourselves for such a condition, in looking back at what we went through with COVID-19, and just trying to figure out how best do we prepare for something like this if it actually does find its way into our country. And so those are the 3 areas of infection prevention and control that we're looking at, which is barrier precautions, safe burial practices, and environmental decontamination. So the major one that we're looking at is in terms of personal protective equipment. And for personal protective equipment, we're looking at things like your headgear, your goggles, your mask, face shields, your gown, the coveralls, aprons, gloves, and boots. And why do we need to look at PPEs? So Marburg virus disease actually spreads mostly through direct contact. This is such as with in instances of where a person has broken skin or the mucous membranes are exposed, either the eyes, the nose, or the mouth. Now, blood or other body fluids of a person who is sick or has come into contact with Marburg virus disease can easily, or has died of Marburg virus disease, can actually cause that particular spread to happen. And also objects contaminated with blood or other body fluids from a person who is sick or has died from Marburg. So this is why we actually need personal protective equipment. So the PPEs actually work as a barrier to protect your eyes, your nose, your mouth, your skin, and your clothes from contact with a patient or with patients' body fluids. And now, specifically for Marburg virus disease, we're looking at 2 aspects of it. So we're looking at the point of screening, when you're screening patients who are coming in, and number 2, when you are the healthcare worker who is actually taking care of the patients in the treatment center. So some of the CDC guidelines that actually have been developed for Marburg virus disease screening usually state that screening can be a non-contact activity. This is basically where you maintain a distance of at least 1 meter from the patient and avoid direct face-to-face interaction, where you can have physical separation with things such as plexiglass, which is preferred. But if in a resource-limited setting where you cannot get the plexiglass, ideally, a distance of 1 meter is preferred. And remember, when you're doing your screening, basically you're asking your patients, if this particular patient who comes in and has the symptoms that Dr. Nyukuri had discussed, and you're asking them, when did these symptoms start? Have you had any history of travel? Like for us now, it would be, have you traveled to Kigali recently or to Rwanda over the last 2 weeks? So that's some of the screening questions. And when you're doing this screening, the CDC guidelines say that if this distance of 1 meter can be maintained, then no additional PPE is required. In the second one, if distance can't be maintained, which is usually most of the time, because most of these patients will present to your triage areas in your accident and emergency department or to your outpatient clinics, and sometimes getting this 1 meter distance might be a challenge. So when this is not possible and you're not able to have this distance, then the recommended personal protective equipment include mucous membrane protection. Here we're talking about goggles and a face mask, sorry, or a face shield and a face mask, and gloves and a gown. Basically, you look like the picture that is shown there. So you have your face shield, you have your face shield or your goggles, and a surgical mask, which is recommended. One pair of clean gloves, non-sterile, and you have your isolation gown, which you can wear. So that is what is recommended from the CDC in regards to just screening patients for Marburg virus disease. And then now when you look at, when you're actually the person who is taking care of these particular patients in the treatment center, whether they are suspected cases or confirmed cases, and also if you're the team that is dealing with environmental cleaning. Now, this is the kind of personal protective equipment that you need to be having. So you're looking at your double gloves where you have your inner pair and your outer pair. You have a gown, actually preferably a coverall, which can cover your entire body. And then you have your head cover, waterproof gumboots, and mucous membrane protection, where you have your face mask and your face and a face shield or a face mask and goggles. One of the things that they say is that sometimes you can use the respirator can be used in place of a face mask because it can be more ideal in where we have a hot and humid climate. But in most instances, it may not be possible for us to have these respirators in place. So what we're looking at is using a face shield and a mask, your regular surgical mask, or if your facility or if you're in a place where you can actually access to things like N95 masks, those ones can also be utilized. But ideally, if you're the person who's taking care of these particular patients and you're dealing with the environmental cleaning, this is how ideally you're supposed to look. And if most of you can remember, this is how we used to dress up when you are taking care of our patients who had COVID-19. So some of these things actually coming in and sort of being like a repetitive aspect to this management, only that at this particular point where we're having these PPEs, this is now what in IPC we call transmission-based protection. So we are looking at the aspect that the Marburg virus disease is actually spread through contact. So we have to limit contact between the healthcare worker and the patient, and to ensure that we follow appropriate procedures when moving from one patient to the next during the treatment, and also for the team that will be doing the environmental cleaning, that they need to be properly protected as they go around and spraying the high touch areas with a chlorine-based solution. So Daktari had also discussed about supportive care for this particular patient. So we talked about your fluid replacement, managing your symptomatic management, and respiratory support. And now one of the things that we need to begin to think about, especially in regards to IPC and in regards to cases of such illnesses or infections, is to start thinking about how are we going to manage these patients? Are we going to designate a particular area where these patients are going to be managed? If I speak for KNH, we have our infectious disease unit, which would ideally handle these particular cases. But even for us, we're looking at aspects of if we do get Marburg virus disease in the country and the number of patients keep increasing, where else are we going to take these patients? Because one IDU may not be sufficient enough to cater for all the cases that will be coming in if we think about a worst case scenario. So we're thinking about, will we need to put up like a field treatment area, a field treatment unit for these particular illnesses, for these particular patients? And number two, we're looking at how do we increase our human resource capacity for the people who are actually going to be taking care of these patients. And here we are looking at aspects of training for our staff and sensitizations. And this is one of the sensitizations that we're doing, because also a good aspect of prevention is actually community awareness. So putting the information out there so that the community can also understand that this particular disease is there and we are at risk that it will come to us, and for us to take the initial steps to work on a good preventive systems. So this is one of the things that we are doing in regards to our sensitization of both our hospital staff and even the community and other healthcare workers. So those are the kind of questions that we are beginning to look at as IPC. The good thing is that we have a good background when we were managing COVID-19, and also having had teams of healthcare workers who had also been trained in management of Ebola. and some of them actually having gone to Liberia and Sierra Leone during the time when there was the Ebola outbreak, and that they were able to be their hands-on and to learn how to contain these diseases. And now looking at how do you utilize such resources within our particular facilities, within our particular hospitals, in order to help to train our healthcare workers, in order to get prepared for any outcome that may prevail. So in terms of that preparedness and response, we are talking about surveillance, where we're looking at early detection is key. So we need to establish robust surveillance systems, and we're looking at creation of rapid response teams where we have well-trained teams are crucial, and where they're needed to respond promptly. We're looking at community engagement, like I said, having these webinars, having sensitizations, just to make this thing to become top of mind so that we can be able to plan better as we look at how we're going to respond to this infection if it does get to our country. And then also looking at risk communication, where we're looking at clear communication is essential to prevent misinformation. And we know there's a lot of misinformation. Misinformation can actually happen in this day and age where social media is quite vast. Many people have access to it. It's very easy for people just to decide to post anything that they want and give really bad information that can actually be detrimental to our teams who are working in these particular areas, and also to the patients. So in conclusion to this, we know that it has a Marburg virus disease has a high mortality rate, and it necessitates rapid action, and prevention is critical, as in prevention is the key. So strict infection control measures are essential, and looking at basically things like this, the webinars, knowing what kind of PPEs you require, ensuring that you have people who are ready to do environmental cleaning if need be, if we do get to that position where these conditions are. And then we're looking at also research. Like Dr. said, there is no conclusive vaccine. And the reason, like he said, is that the numbers for Marburg have not been significant enough for, let's say, the world to actually think about fully funding vaccines and doing clinical trials, because the numbers have actually been quite minimal, and the cycle of the infection has not been that prolonged. So that's one of the things, the other things that you can be looking at is in terms of research in this particular area. But the key take-home message for me will be, given the situation that happened in Rwanda, where it was mostly healthcare workers who are affected, I want to emphasize and just remind people about the 5 moments of hand hygiene. Where you're working, this is just a basic standard precaution. And this is something that it's actually been shown to save lives and reduce the number of healthcare associated infections and things like that. Just remember your 5 moments of hand hygiene: before touching your patient, before cleaning or an aseptic procedure, after body fluid exposure and risk, after touching the patient, and after touching the patient surroundings. So ensure that either you're using your alcohol-based hand rub, or you are actually washing your hands with soap and water, to actually just ensure that you're reducing the possibility of you being infected by these infectious diseases. And then once you're in a place where you're dealing with, let's say, Marburg virus disease, and you're dealing with your suspected cases and your confirmed cases, then now you can move to your transmission-based precautions, which we have talked about, the type of PPEs that you're supposed to wear, and how you're going to just handle the patients as you're working with them. So our main key our take-home message from the infection prevention unit is just prevention is better than cure. So just keep at it, ensure your 5 moments of hand hygiene for standard precautions. We keep praying that this Marburg will not find its way into the country, but it's also good for us to be prepared. So standard precautions and transmission-based precautions will be quite key in us being able to contain this particular disease, if and when, hopefully never, if it ever lands in our country again. So thank you for listening to that short presentation, and I think we can start off the discussion, and I'll stop my sharing right now, and I'll invite Dr. Linus Ndegwa from the Kenya CDC to give us his comments in regards to Marburg virus disease and what lessons have we learned from COVID-19 and from the various, from the Ebola in Sierra Leone and in Sierra Leone and Liberia, and what can we do as a hospital, or even what can we do as healthcare workers in terms of preparing ourselves to handle such illnesses? Dr. Ndegwa, welcome.
Thank you, Dr. Mbuvi, and thanks, Dr. Nkudia, for the wonderful presentation. Hope that you can hear me well.
Yes, you can. We can hear you well.
Yeah, thanks. Yeah. And one of the key things that really you mentioned, and Dr. Nkudia has really mentioned, is once we know the disease, what causes it, how it is transmitted, the next thing that really is important for us is really about preventing and making sure that we don't get infected. And the lessons, as you've rightfully said, we've learned quite a lot, and this is why it's important for us to keep on, sharing the info as we get it. And one of the things that I would like just to show us is what has happened, especially in Rwanda. I don't know whether you can see my screen.
Not yet. Maybe you can try share again.
Okay. And now?
Okay, yes, now we can see it. Yes, we can.
So what you've just mentioned is really and I have seen one of the questions about somebody saying about patient zero. If you see this slide, which was really shared to us by WHO in Rwanda, and this is really what helps us, and I would like us really to understand and to make sure that we put our measures in place. If you look at this King Hospital in Kigali, actually, because that's where most of the cases were found, and if you can, let me try to see, yeah, my cursor, yeah. This is patient zero, who actually is, are not there today. But I can see most of these in this circle who are infected actually are 15 health care workers, staff, 15 in ICU, and 2 in internal medicine, and 1 in emergency. And if you look at that, of all the cases, much of it has been contributed by the healthcare workers. And I've loved what you've just explained, Dr. Mbuvi, in terms of our standard precautions. And actually, it's known and it's clear scientifically that our hands are the best vehicle of transmission of most of these organisms. And this being hemorrhagic fever, sometimes you may not even see it, and once you touch the patient and you've not taken the precaution, the standard precaution that are really required, which is supposed to be naturally within healthcare provision, and it's natural. We know it with our mind, it's ignoring, but practice is actually very, very low, especially one, as you mentioned, the hand hygiene. Before you touch the patient, we are supposed to clean our hands. After touching the patient, clean our hands. That rarely happens in our setup. And this really, if you look at this, and diagram about Rwanda, that's really where it occurred. How we touch our patient without really being conscious about transmitting, because once you touch a patient, you actually pick organisms from that patient, whether the normal flora or the infectious, and you take them to the next patient. And really, this is one of the key things that I would like us really to take home, that now that we are on high alert, and we need to really keep our guns high in terms of standard precaution, mostly PPE and hygiene, because that's the only way that this virus is transmitted. One is, as you've rightly said, through contact, and then especially for the fluids, which the patient may either vomit as, even urine, as Dr. Nyakuri has, told us in his presentation, or any body fluids. And remember that incubation period is very short, between 2 days from exposure to 21 days. And so sometimes it's very hard for you to really suspect a patient who is within those 2 days of contact. And that's why you can see that quite a number of healthcare workers in this hospital in Kigali, they are all under isolation and being monitored for those 21 days. And the red ones are actually those who have succumbed in Kigali. So it will be very, very unfortunate for us. Now we know what has happened there, and then we don't really practice. And of course, you may never know. And this is really starts mostly in the emergency department across the country. Those, and as you register those health a patient who comes, starting from triaging, we need to have a very strict triaging area, asking the patient what symptoms they have, and those people working the trial, the nurse or whether the support staff, need really to be on high alert and protective gear on, and really putting on standard precautions, practice, not ignoring. Those skills need to be practiced. I think that's what I can say at that moment, Dr. Mbuvi, and maybe if there are, there are quite a number of questions that we can be able to address, but I wanted really to emphasize the importance of really standard precaution. Dr. Nyankuri mentioned and of the trial drugs that are being used. Now, most of this, if the case is detected early, actually symptoms seem to be, disappearing early enough. But of course, by the time that the patient comes and you start those trial drugs, it's a bit late. But if captured early under those on experimental, from the studies that are being done, it saves some lives. So it's still a lot to learn from this virus. It's part of the viral hemorrhagic virus like Ebola, and we have really to be very, very careful, and to be careful throughout in our practice. I want to really indicate that I think in 2014, we were doing some studies at KNH on pathology and patients who, especially pediatric, who had died of respiratory illness. And we untrained the pathologists who are doing the postmortem on how to protect themselves. But they left the gun down, and once they opened one of the patients, they found that patient had really active TB. That's what killed him. And at that time is when they were looking for masks. And I think it's not good to start looking for protective measures when you have seen the case, but let us be ready, protect ourselves, practice the standard precaution early enough. Back to you, Dr. Mbuvi.
Oh, thank you so much for that, Dr. Ndegwa. I appreciate knowing that patient 0 was actually found. That is actually quite a good take on it. Dr. Nyukuri, we'll just go through a few of the questions. And Dr. Nyukuri, there's a question here in regards to, it says, can the patient present with cough also? And also, can the diagnosis be confused with malaria? And what of these species of Lake Victoria Marburg could it be that it's found in the lake region, as the name suggests? One of the things, I think before Dr. Nyukuri answers, one of the things that we noted was that from the clinical symptoms that these patients present with, it can be like any other infection that we have. And most of the time we tend to think that it's probably malaria. Your patients who come in with the fever, the nausea, the vomiting, the diarrhea, before they actually start presenting with the hemorrhage and things like that, it's quite difficult for us to differentiate them. But the key thing is having a high index of suspicion, and also the questions that you'll ask the patients, history of travel. Like right now, the thing will be now history of travel to Rwanda, or history of travel to Kigali, Rwanda. or coming in contact with anyone who has traveled recently to Kigali or from Kigali to Rwanda. And I think maybe Dr. Elliot will also tell us, but I think no cases so far have been reported in Uganda and in Tanzania. So we're still looking at the aspect of it just coming in from Kigali. Dr. Nyukuri, will you be able to answer that part in terms of now how to do the differential diagnosis with malaria, and maybe talk about the Lake Victoria Marburg?
Thank you, Dr. Mbuvi. Actually, you have pretty much answered the first part of the question. So if you remember the initial presentation of Marburg virus, as I said, it will present with an abrupt onset of fever, chills, myalgia, general body weakness, basically like any other acute febrile illness. And it's very easy to confuse it with other acute febrile illnesses like malaria, like influenza even, and so on. So I think the important thing, as Dr. Mbuvi has said, is if there is an epidemiological link, so a history of travel and who is very important. And then number two, especially if you look at the onset of symptoms, some of these acute febrile illness will progress. They're still acute, but it will progress maybe over a day or two, as opposed to Marburg, whose symptoms tend to start really abruptly. We're talking about minutes to hours. But having said that, it's important to have a high index of suspicion, and it's important that these patients are screened for any other acute febrile illness as part of the diagnostic workup, so that we don't miss the other common illnesses. In terms of why it was called Lake Victoria Marburg virus, I am not sure. Maybe because the original monkeys came from Uganda, which is next to Lake Victoria. But having said that, it doesn't matter which strain you get, the clinical presentation is pretty much the same. Yeah, back to you, Dr. Mbuvi.
Okay, thank you for that response, Dr. Nyukuri. And as you move down on the questions, I think you've also answered another question that was following from Dr. Rosemary, who was asking about her comment that I think the current clinical climate we are in is in a difficult position. There's currently a viral infection that is circulating with sore throat, severe headache, nausea, and vomiting. And I am seeing it in my pediatric patients, and they're testing negative for flu and COVID. So this is really the commoner presentation of most viral infections, which is true. At which point do we suspect Marburg? How do we protect ourselves as healthcare workers dealing with these patients, since we may miss the diagnosis? So Dr. Rosemary, I think Dr. Nyukuri has mentioned that we need to get that epidemiological link. And then in regards to how we protect ourselves, like we keep insisting, standard precautions. Just ensure, as in every single day as you go to work, as you're working with this patient, just ensure your standard precautions, because that is the one thing that will just keep you from having to putting yourself at risk with these patients. Then once either an epidemiological link has been established, and then now we're looking at dealing with a patient who's either a suspect or is a confirmed case, then now we move to our transmission-based precautions, where now we put in the full PPEs and ensure that we just follow all the guidelines that have been put in place to deal with that. Yeah, there's a comment from a gentleman by the name of, I think it's Nyagundi. He says, hand hygiene for MVD, best bet is nitrile gloves or latex gloves if the disease becomes common. Yes, that is true. Like we've said, the reason why we are focusing on hand hygiene is because it's a standard-based precaution. Since we have not yet reached a point where we have a patient who has an established epidemiological link to Marburg, then we just need to maintain our standard precautions, which is what we will keep emphasizing, because that is the first step to us protecting ourselves. Then now when we come to the nitrile gloves or the latex gloves, which can be utilized, but then now we'll be looking at the point of transmission-based precautions. James Olo says, just want to commend the presentation and fantastic responses to the questions. Thank you so much, James. Were there any fruit bats in the Mount Elgon caves? Yes, they were. Actually, when I was going through that particular, going through the history, I actually found, yes, that particular bat is actually found in the Mount Elgon caves. Dr. Kigathi was asking, what of contact tracing? Is MOH tracking those arriving from Kigali, since we still have flights and buses back and forth? Maybe Dr. Ndegwa can inform us if there's any contact tracing that's currently going on. Honestly, for our part, we haven't really seen any release from the Ministry of Health, but I know that for a fact they will be having, at the point of entry, they will be ensuring that we are screening people, because this is something that is of importance. But maybe Dr. Ndegwa, through the CDC, can be able to answer that question for us. Dr. Ndegwa?
Thanks, Dr. Buvi. Yes, actually, the ministry is on high alert, and there's the incident management system that has already been set up together with, the MPOX, which has been going on. So at all points of entry, there's a lot of screening that is going on. So especially on the crossings, both in all the airport and land crossing, that screening is being carried out by the Ministry of Health, especially the disease surveillance unit. So it's going on, and it's really a very important point to again re-emphasize our history taking, and especially for the records when you are registering the patient, that important history of travel is very important. Our history of contact of a patient who are traveling to Rwanda or those signs, it's very, very important to be, recorded and be on high alert. Thanks, and back to you, Dr. Buvi.
Thank you so much for that response, Dr. Ndegwa. I believe the disease surveillance unit will be on top of things just to make sure that we do not have any incidences coming into the country. But like we said, the reason for us having this webinar is just to educate the people who will join, so that you can begin to put Marburg virus infection at the top of your mind, and also just maintaining standard precautions. Like we said, if it's healthcare workers who are mostly found to have the virus in Rwanda, then we really need to ensure that we also now take charge of our own safety, and just ensure that we just maintain the standard precautions, and not just by knowing them, but actually, as Dr. Ndegwa said, by actually practicing them. So hand hygiene, standard precautions, we need to continue with that. Joyce Ngatia is asking, how do you escalate care or report a suspected case? Dr. Ndegwa, any answer on that?
Yeah, depending on where you are, and especially if you're in the country, I think we have 26 emergency operation centers across the country. So there are numbers that you can reach out to your EOC. If you have no EOC in your county, your disease surveillance, if you actually reach out to your disease surveillance in the county, then that should be able to reach out to the national EOC, and action can be taken very, very fast. And we are using the same mechanism for MPOX. So I can't remember the number very well on top of my end. So, but I think that number has been really circulated across the country. Over. Now, on that note, Dr. Buvi, I wanted to really help ourselves again by just showing us this simple clip of hand hygiene, and especially in our setup, how we behave. And I think they should be able to caution us. I don't know whether you can see my screen, Dr. Buvi.
Yes, we can. We can see your screen. Yes.
Yeah, this is a clip of a typical day in the hospital, and I'm sure we can attest to this kind of behavior to all of us. It's just showing us how in transmission is goes across our facilities.
Okay.
And sometimes, if we wear gloves and think that we are protected, but those gloves becomes actually a very important vehicle of transmitting infection across the hospital, from patient to patient, from patient to healthcare worker, from healthcare worker to the next healthcare worker. You can see we are really talking about digitalizing our systems and how often do we clean these areas. And it's very, very important in terms of really following our standard precautions. Yeah, I just wanted to share this so that it raises our awareness and know that it's important to really know hand hygiene is a critical point for us to stop the spread of Marburg and any other transmission, including multi-drug resistant organisms in our setup. Back to you, Dr. Mbuvi.
Thank you so much for that. That's actually a very nice clip to show us why we'll keep emphasizing on basically starting out on your standard precautions. Then after your standard precautions, then now we'll start thinking about our transmission-based precautions when we now have a suspected case. And remember, transmission-based precautions are usually based on exactly what it says, transmission-based. So Marburg virus disease is basically spread through contact. So when you're talking about contact, you're looking at how am I going to prevent that spread of this particular illness from one patient to another, from the patient to the healthcare worker, or from the patient to any other person who might be within that hospital setup. So that's why we're looking at those particular standard precautions, and then looking at your transmission-based precautions as well. I can see more questions that are coming up. This one about are our frontline workers identified and trained to avoid confusion, which were witnessed during COVID-19? This has been asked by Joyce Kidogo. Joyce, what I can say is we learned very, very valuable lessons from COVID-19. We know where we went wrong. We know where we maybe did not put particular emphasis on in regards to our preparedness. But now we're looking at how do we use those lessons that we learned during COVID-19 to now be able to do exactly what you're asking, to identify and to train our frontline workers. And one of the things that we have started doing is basically like what we are doing right now, how we're doing this particular presentation, this webinar, to just sensitize people on that there is Marburg, and these are the things that we need to start thinking about and to look at. Looking at the question in regards to the confusion that was witnessed there, then now it means that at your level or at your facility level, it's time for us to start thinking about how do we become proactive in order to be able to prevent this thing from becoming as bad as COVID-19 was. Because now we've already learned the lessons. Now, which lessons do we pick from that time of COVID-19, and what can we actually begin to put in place, or what can we revive from the lessons we learned in COVID-19 as we move forward? Then Sylvester Owende is asking, how do we handle Marburg bodies? Okay, so Sylvester, one of the things is for Marburg bodies, it's the same, believe it's same for all viral hemorrhagic fevers, that the bodies have to be sprayed with a chlorine-based solution and to be double bagged and then to be buried, just to minimize any opportunity of it being able to spread. Because as Dr. Mikuri had said, that even someone who's handling bodies can actually have the transmission can still be there. So we're looking at same thing, your transmission-based protocols, and you're looking at double bagging the body, ensuring that the body has been sprayed with a chlorine-based solution. Yes, those are the kind of things we've said. And like Dr. Lennas had said that training also of the pathologists and the people working in the morgue is also is very vital, so that they can actually understand how to handle this body, so that we do not have that you've done all the good work within the hospital, and unfortunately the patient has passed on, and then the ball is dropped when the body gets to the morgue. So that's one of the things. Jacqueline Nginga is asking, are there comorbidities or other factors that contribute to the morbidity and mortality of MVD? Dr. Nyukuri, any comment on this in regards to comorbidities that can maybe contribute to the morbidity and mortality of patients who have Marburg virus disease?
That's a very hard question to answer because one, of the sporadic nature of these outbreaks makes it very difficult to study. Looking at the numbers also, I don't know how much information you can glean from that, and also the high mortality in the big outbreaks. So when you're talking about 90% mortality, one starts to think maybe everybody is affected the same way. So having said that, I just think there's a lack of data there. But we also know that patients who are immunocompromised tend to fare worse in any disease situation as compared to patients who are not. So my response there will be, especially for patients who are immunocompromised, very young, very elderly, it's possible they may be more at risk. But all of us need to take precautions because, as we have seen, the mortality rate is very high. So let's not take chances with this disease. Back to you.
Thank you so much for that answer, Dr. Nyukuri. And I think that also brings about the aspect of where, as we were thinking around comorbidities, and we can also remember that you can actually have a comorbidity and still get Marburg virus disease. So as we look into our centers where we work, we need to start thinking about not just looking at it as just we're going to be dealing just with Marburg virus disease, but this patient can also come with other things. So we need to start thinking around that. There's a question by Dr. Kigathi who's asking, how has KNH as a National Referral Center prepared for case zero? God forbid it happens. So Dr. Kigathi, this is one of the ways that we are preparing. So we reactivated our public health emergency committee, and one of the things that came out was that we needed to do a webinar first to just sensitize people around what Marburg virus is and how do we get prepared. The other thing is that now we're looking at all our healthcare workers who were trained during the time when there was the Ebola outbreak in Liberia and in Sierra Leone. We're looking at the teams that were trained during the COVID-19 outbreak so that we can begin sensitizations and begin maybe retraining for them. And then now doing sensitizations within the hospital and mostly initially focusing on the areas where patients usually come in through our facility, which is the accident emergency department, our pediatric emergency unit, our corporate outpatient center, the outpatient clinics, radiology unit, and the labs as well. So that is where we are starting. So it's a cascaded thing that we are currently doing in collaboration with public health, IPC, infectious disease unit, in full support with the management of the hospital, and just looking at what reserves do we have. We're also going back to look at what available PPEs do we have? What's the stock that we have? Do we need to start thinking about increasing the stock that we have in regards to our PPEs? And also, as I mentioned, in regards to our standard precautions, just sensitizing people on the use and utilization of alcohol-based hand rubs, washing your hands after every incident that you have with a patient. So that is one of the things. And the IDU unit under with Dr. Nyukuri working in the team from IDU are also prepared in case we do get a suspected case or, God forbid, even a confirmed case, that we will be able to take care of them in our IDU, which initially, even Dr. Ndegwa can attest to this, that the IDU was actually designed to be what we call an ETU, an Ebola treatment unit. And this is quite capable of handling any infectious diseases that may arise. So we do have that first step, and looking at, as we progress, God forbid if it does happen, then we believe that also the Ministry of Health will kick in, and with finances and other resources being provided, we will be able now to fully be able to take up this particular challenge and be able to work on it. Yes. There's a question from Stephen Mundia who's asking whether there's a hotline number to report an incident. Like Dr. Ndegwa said, there is a number that Ministry of Health had issued in regards to Mpox. And I think if you're in a county, the emergency operation centers usually have a contact number, and then they usually escalate it to the National Emergency Operation Center. So one of those things, I think it's, I believe if you check the Ministry of Health website where the Mpox posters are, there is a specific number that they had issued for people to report any Mpox cases that they, or any suspected Mpox cases, and I believe it will still work if we get to a point where we do have a suspected case of Marburg virus disease, and this is by mentioning that the patient has actually met the epidemiological link with the symptoms, and then the epidemiological link to Kigali, then to Rwanda, and then that now can actually begin us to have the process of us, getting these responses done. Yes, I believe most of the other questions, Dr. Ndegwa has actually been answering them as they're being put up. And we have currently gone through about an hour or so of this presentation. And what I can say is that we, as KNH, we will continue updating as this particular, as we monitor the situation in Rwanda, and as the disease surveillance unit in the Ministry of Health continues also to monitor the situation in the country. In case of any updates or any news or information or any new information that we may need to put out there, these webinars will still take place. We will still look for ways to just help to disseminate this data, and just to see how we can work together as healthcare workers within the various institutions that we are in order to help us to be able to combat this illness if and when, if God forbid, it actually lands in the country. So I would like to welcome Dr. Nyukuri to give us his closing remarks, and then I'll also invite Dr. Ndegwa to give us his closing remarks, and then we can call it a night. Dr. Nyukuri?
I think we have mentioned most of what needs to be said. One thing we should be aware of, and we have seen this in situations where patients are suspected to have a new contagious illness, is these patients are shunned. These patients do not receive the care they deserve because we are afraid. And unfortunately, lessons that we learned during the COVID pandemic is it contributed to a significant number of morbidity and mortality. So let us attend to all the patients, including suspects. While we are doing so, let us maintain appropriate infection prevention measures. And let us always keep ourselves abreast with new information. Let us know this, update ourselves on the situation, so that we are well prepared in case of any eventuality. Thank you. Dr. Mbuvi? Are you there?
Sorry, Doc, my screen just went off for a moment, but thank you for that input. Dr. Ndegwa, any remarks from your end?
Thanks, Dr. Mbuvi, and I think this very good step forward. One of my encouragement, just borrowing from what Nyokulia said, is please let's not panic when you get a suspected case or when history you are taking and you get that patient is from Rwanda. What has happened is, as we've learned, is people panic and then some health workers run away, and so the patient also gets scared. So the importance of sharing this knowledge is, as you know, as healthcare workers, we are frontline workers, and we need to have knowledge. And once you have knowledge and you are protecting yourself, you are actually practicing standard precaution. You will not be worried even when you know that this patient has come from, it's a suspect case. Maybe that suspect case may be coming as a suspect because has been nabbed at the POE, like in JKI or anywhere or in Namanga, and brought straight to KNH. So please don't panic, or whether it's in your county. Just take history, protect yourself, examine that patient, and ensure that you are protected. That way, we will not have transmissions, even if that case turns out to be positive. Now, the other important thing I wanted to say is that the Marburg virus is, one of the goodness about it is easy to destroy, and it can easily be eliminated by heat within 30 minutes of 60 degrees Celsius, or even by light or just sunlight, or bleach, which is chlorine jig that we use, or soap and water. All this really can eliminate the Marburg virus, and that's why it's important to practice standard precaution. Let our cleaners also be trained to protect themselves, so that even if there's a suspect case, how do they clean the surfaces, clean the floor, or any contact or any spills, so that there's no transmission within our facilities. And I think the best thing is to keep on reminding one another, be one another's keeper. If you see your colleague has not washed hands or hand hygiene, please remind that colleague. Hand sanitizer, let it be easily available. Let us use it during warm downs where we are seeing patient in the outpatient. Let's not really, I know there's this notion that we are too busy. Let's not be too busy to infect ourselves. Take precautions as we take care of our patient. Thank you, and back to you, Dr. Bubu.
Thank you so much for those reiterations, Dr. Ndegwa and Dr. Nkuri. As you've said, we need to really care for our patients. Regardless of what condition they come in, we need to remember that as healthcare workers, we are their last line of defense, and we need to be empathetic to their situations. There are several questions in regards to the turnaround time for PCR. What I can say is we were to have one of our presenters from the National Public Health Lab. Unfortunately, we are not able to get them, but in our next presentation, we will actually have someone from the lab who can take us through in terms of now how to take the samples, how long it takes for them to actually run the PCR. Maybe Dr. Ndegwa, you might be knowing how long the tentative TAT for the PCR could be.
Yeah, but not on top of my head, not so clear, but between 4 to 6 hours PCR, they can get the result. But let me say what makes the delay, especially in this diagnosis, is that if, for example, let me give an example, like the results that we are getting for Mpox is one lab, like the National Public Health Lab test, and once they find it is positive, they have to have it confirmed by a different lab, especially in KEMRI or CDC lab. So once there's that concurrent, that's when those results are released, and that really takes almost a day. And so that's really what made it, because it will be banned to release a false, negative result or a false positive. So those are some of the measures that I know the lab, once they come, they'll put in to us as we learn more. But I think that's really what delays, and PCR is 4 to 6 hours, you have the results. But to make sure that it is real positive or real negative, then 2 or 3 other different labs have to confirm the same results. Over and back to you, Dr. Mbuvi.
Okay, thank you for that clarification, Dr. Ndegwa. It's true that we do need confirmation for such results. It could be very detrimental to release a false negative, and even a false positive. It can be very detrimental to the patient and even to the healthcare workers. So, ladies and gentlemen, thank you so much for giving us your time. Thank you so much for agreeing to join us in this discussion. We have enjoyed your questions. We hope that you have grasped something from this presentation. And like I said, we will ensure that we keep you updated. If we will need to do another presentation, we will actually plan for that. But this was just the first step in us taking charge and looking at ways in which, how do we prevent ourselves, how do we prepare ourselves in case this thing actually, God forbid, it crosses the border and gets into Kenya. We just need to be at top of mind and to be prepared. My parting shot will just remain the same. Standard precautions, standard precautions, standard precautions. Gentlemen, ladies and gentlemen, please wash your hands. Be your brother's keeper, as Dr. Ndegwa has said, and as Dr. Nyukuri has reiterated. Let's be there for our patients. Let's not stigmatize them. Let's actually be who we were meant to be. Let's empathize with them, and we will be able to control this thing if and when, or God forbid, when it shows up. So thank you so much for joining us for this webinar. On behalf of Kenyatta National Hospital and the team, we thank you so much. Thank you, Dr. Ndegwa, for agreeing to join us for this presentation. We appreciate your insights from the CDC and your expertise in this particular field. To Dr. Nyukuri, thank you so much also for giving us the presentation. We thank you for everything. We thank you for your knowledge, and we look forward to other interactions where we'll be able to discuss more in regards to infectious diseases. So thank you so much. I'll take it back to the KNH research team, I think, to end the program. Thank you so much.